We have MAFLD, metabolic associated fatty liver disease, steatosis, NASH with steatohepatitis, NASH subset with fibrosis, and then this final stage going into cirrhosis. This is a discussion about MAFLD pathogenesis. Upper left corner, you're going to see fatty tissue. This is typically adipose tissue, but also you can have fatty changes in the muscle. Releasing free fatty acids, releasing cytokines such as TNF alpha, interleukin 6, resulting in insulin resistance, decrease adiponectin, increase leptin. Down the left lower part, you have what are called stellate cells and HSC activation, resulting in fibrogenesis, Kupffer cells, which are macrophage-like cells, also being activated and further activating stellate cells. Upper right corner, we have genetics mixed with environmental factors. Environmental factors are these high fructose corn syrup sources, plus lots of other sources of simple sugars. Genetics include PNPLA3, HF6, MBOAT, and a number of other genetics. We'll eventually have genetic panels that will help us. Lower right-hand corner, we have the GI tract, dysbiosis, ethanol production locally, altered intestinal permeability. And back to the cardiology story, we want to have our cardiologist understand all these issues and how they interact with cardiovascular risk. Every patient with cardiovascular disease needs to be assessed for lipid disorder, for diabetes, for fatty liver. It's very simple. We just train our cardiologists to look at liver enzyme panels, liver enzymes being AST and ALT, with soft signals when the AST and ALT are over 20, harder signals when the AST and ALT are over 30. When you have a cardiovascular patient, they have lipid panels, and when they are getting ready to be started on statins or any lipid lowering agents, we'll need to train our cardiologists to make sure they have a liver panel on file. Liver tests are elevated. They need to be referred to a gastroenterologist or hepatologist for further assessment. Finally, on this slide, in the center of this, of course, is the liver, where we have ER stress from lipotoxicity, a lot of reactive oxygen species, mitochondrial toxicity, mitochondrial dysfunction. Cell death can take place through apoptosis. There's something called autophagy. In the upper right corner, we have liver cancer. This is typically in patients with cirrhosis, but as you know, we start looking for liver cancer in patients with F3. Back to cardiology. Cardiology needs to know that they may be the only one following the patient, and they need to assess for fatty liver, then bring in additional consultants. So you look at this MAFLD population, which can be up to 30% of the general population. 90% typically have steatosis. I tend to quote 85% here, 15% with NASH. Have those patients with NASH, inflammation, other 20% of those get fibrosis and are at risk for cirrhosis. Of course, downstream includes decompensation and HCC. This is a little bit more detailed in terms of what the liver biopsies would look like. I'm bringing this up for cardiologists to know. We rarely do liver biopsies, but people at risk for progressive liver disease are in this box right in the center. Diabetes, hypertension, obesity, especially truncal obesity, and rising liver enzymes, it's an important dynamic, and a shift in the AST to ALT ratio. The AST is more than 0.8 of the ALT. So let's say the ALT is 100, the AST is 80. That's a flag for current fibrosis or risk of progression of fibrosis. And if the AST is greater than the ALT, very high risk for cirrhosis in those patients. This gets back to some definitions. I'm not going to go into this in great detail, but the upper right-hand corner does talk about ultrasounds. Hepatic ultrasound specifically, cardiologists can easily order the liver ultrasound, and if the liver ultrasound is normal, they don't necessarily need a referral to a hepatologist or gastroenterologist. But if the ultrasound is abnormal, it's very important for those patients to be referred for specialty care. In the middle box, it talks about the liver biopsy being gold standard, but this is going to be replaced by blood tests such as cytokeratin 18. There's a new commercial test called ELF. They'll be released from Quest soon via Siemens. And then NIS4, another blood test, will be available through LabCorp, being developed by GenFit. I think we've discussed most of the other tests that are in here, although FIB4, fibrosis 4 score, is probably the best free non-invasive combination calculation, although APRI is good, not necessarily excellent. Another thing I'd like to have as a take-home message is that we should not be measuring ferritins in our patients. Ferritin is like a sedrate or C-reactive protein. It's an acute phase reactant. This is very dynamic. This is what we talked about, including a patient today in clinic. Fibrosis is reversible. Fatty changes are reversible by behavior modification, weight loss, stopping alcohol intake. All key parts of this. Bariatric surgery, very important part of this as well. And early fibrosis, yes, it's a marker of risk of progression, but we have rapid progressors, we have medium progressors, we have slow progressors. And the slow progressors, of course, are going to be more likely to be amenable to interventions. Now, when we're talking to cardiologists, you look up in the upper right-hand corner, there's a variety of different lipid disorders that the cardiologists are going to know more about than we will. Beta lipoproteinemia, lipodystrophies, cholesterol ester storage disease, Wolman disease, which is also called LAL-D, lysosomal acid lipase deficiency, which we test for in our clinic occasionally, Wilson disease, and then we talk about these different genetic changes, which PNPLA3 is the most common. But there'll be a variety of other tests that will be part of those panels in the near term. Cardiologists are evaluating patient for diabetes, at least. I think they ignore the liver, but knowledge of that is very important. Then the lower right-hand corner, it says drugs, amiodarone, commonly used by cardiologists for different types of arrhythmias. The intravenous amiodarone was very liver toxic at high dose. More recently, the oral low-dose amiodarone is much less liver toxic. And whenever you think of MAFLD, you have to think of other diseases. So right now we're interjecting this or interconnecting this with cardiologists. That's the lower left-hand corner, including cardiac arrhythmias. The upper right-hand corner, we talk about congestive heart failure, myocardial infarction, and stroke. What's not on here, which should be on here, is this issue about orthopedic disease. That's missing. We talk to every patient about spinal, hip, knee, ankle. But what is on here in the upper left corner, which the cardiologists need to know about, is this issue about chronic kidney disease. That chronic kidney disease is not just from hypertension, not just from diabetes, but from this general inflammatory stage of MAFLD, metabolic associated fatty liver disease. So, proportion of fatty liver patients along the left with comorbidities, it shows that over the last 2 decades, 3 comorbidities has gone from basically about 5% up to 20%. So comorbidities, hypertension, kidney injury, diabetes, dyslipidemia, cardiovascular disease, including heart attacks, strokes, heart failure, all meld into this. Then this risk of death, it continues to go up as you have more comorbidities. So it's very important to count these comorbidities, know the comorbidities, and talk to patients about the risk of death. So on here, there's this crosstalk basically between the liver and adipose tissue. They're constantly talking to each other, transferring information, transferring fat back and forth. partnering in this insulin resistance profile. Lower left-hand corner, back to the cardiology messaging. Talk about this dyslipidemia, atherosclerosis risk, to calculate the cardiovascular and atherosclerosis and kidney risk. And then the very bottom line is very interesting because hypercoagulation, hyperfibrinolysis is related to things such as DVT, progressive liver disease, progressive heart disease. Now, upper right-hand corner, we've got this issue about malignancies. We need to teach the cardiologist to teach the patients about cancer risk, even though we're not going to ask the cardiologist to do surveillance. They need to keep that in their educational message, just like we do in our liver clinic. So fatty liver is independently associated with a number of subclinical atherosclerosis outcomes, including high-risk plaque, cardiovascular events that we've talked about, stroke risk. These are all part of this problem of arterial stiffness and endothelial dysfunction. This is a display that just gives you a nice cartoon about the fatty liver interacting with the gut, muscle, cardiovascular disease, and the pancreas, and of course, peripheral insulin resistance. There's another summary. The left side's a little bit tilted sideways. It talks about SNPs, dysbiosis, adipokines. The center brings forward aortic valve, which we didn't talk much about before, or vascular wall changes, but these can take place through hypertension, hyperlipidemia, morbid obesity, and eventually can have aortic dissection. Bottom part, lots and lots of detail about what goes on between inflammation, signaling, angiogenesis, hepatokines, redox, hemostasis, and lipid profile for your studies later. This is MAPLed and cardiovascular event, different groups of different studies with the high risk of MACE, odds ratio 1.64, cardiovascular events in general 1.77, prevalent cardiovascular disease. Large number of patients in these studies, large number of studies, high risk. All right, so this is a nationwide cohort that actually took place in Korea, but does relate to us because we have a large number of patients of Asian origin. So the hazard ratio on the right side for cardiovascular events, they don't have any fatty liver, 1. Fatty liver only, 2. But once you get metabolic associated fatty liver disease, you start getting up a much higher hazard ratio between 1.4 and 1.5, and then you bring in that fatty liver plus peripheral events, different types of fatty liver disease, then you've got even a higher risk of cardiovascular events. So GGT is a liver biomarker for cardiovascular risk. It comes out of the liver. It's increased in fatty liver. It stands a good biomarker linked to increased risk of cardiovascular disease, including stroke. Every one of our liver patients, we do an ASCVD risk score. So we talk to our patients about heart disease, kidney, creatinine, talk about their stroke risk, liver progression, general cancer risk profile. Proteomics are being brought forth in cardiology faster than in hepatology. There are proteomic profiles that predict very accurately cardiovascular risk, but we don't know how to use that in liver disease yet. This is data on the GGT, all these different cohorts, large number of patients, follow-up, sometimes up towards 15 years, works independent of BMI to predict cardiovascular events, including coronary artery disease, heart attack, myocardial infarction, and heart failure. On every one of our patients, we calculate a FIB4. A FIB4 greater than 2.67 is independently associated with higher incidence of MACE and NASH, NAFLD groups. What is happening in these patients as they have progressive fatty liver disease, left ventricular undergoes remodeling, becomes more stiff, more diastolic dysfunction. So just a simple echo can tell you a lot about extrahepatic disease. Lipids can include high triglycerides, We don't measure cytokines, we don't measure angiogenesis, we're not measuring hemostasis, but so you know, in general, these things are changing in a bad way, a pro-inflammatory way, towards angiogenesis, towards clotting disorders that can worsen liver disease by microthrombi in the liver portal venules that are there. Patients can have prolonged QTC, ST segment abnormalities, other electric conduction abnormalities, aortic valve calcifications and weakening. Of course, hypertension can get worse, and endothelial dysfunction is an endless cycle in the liver towards bad things. There's a risk of stroke with different biochemical markers. Basically, the biochemical markers aren't really useful for saying the risk of stroke. You can see these biomarkers are very prevalent, but in terms of crude effect, it did not have much effect. So I'm showing you a lot of positive information, but I'm going to show you some negative to keep things balanced. So there's a personal and family history. So if a person has diabetes, it's bad, but if a person has diabetes and has 3 other relatives with diabetes, and 2 of those 3 relatives have cardiovascular disease, this is definitely much worse news for that patient in front of you, unless he told you everybody else in the family was negative. Chronic kidney disease, we talked about changes in GFR. As people have progressive fatty liver, their GFR can fall by 10 to 20 points. This can be an overlay of dyslipidemia, more likely diabetes, but the visceral obesity alone is an important driver of this also. This is what happens, renal functional parameters in patients with NASH and controls. So we're here to talk about cardiovascular disease with the renal as part of the cardiovascular bed in the abdomen and the chest. NAFLD can have extrahepatic manifestations. I think we've discussed everything here except for hypothyroidism, psoriasis, and PCO. You have this disease state. It's your obligation to monitor the patient for all these different conditions. So twice a year, thyroid test, good skin exam. In women of childbearing age, you're going to be thinking about polycystic ovary syndrome. More information, sleep apnea, restless leg, osteoporosis, urolithiasis, periodontitis. All my liver patients have a 5-step dental cleaning protocol they're supposed to follow each day. Oops, let's see. Single disease, no. We've covered everything here. Just giving more numbers. More numbers here as well. So some summary about these controversies about NAFLD. We've got increased risk of atherosclerotic disease, hyperlipidemia and its consequences. Diabetes can hurt the eyes and kidneys, so important to look across all aspects of this, get that weight under control. Think in the next year how these genetic sequencing tests might fit in with our program. I can't tell you quite yet, but I'm ready to order them if they become available. Okay, at conclusion, we talked about that one already. Every cardiologist needs to be a hepatologist. Look at the platelet count. It's a cheat sheet. Under 150, they've got F3. Under 100, they've got F4. We as liver doctors need to making sure we have an EKG on all of our liver patients. And once they get over 50 years of age and have a long diabetes history, I'll definitely be getting an echo on those patients. Risk groups, you're going to do ASCVD, you're going to do your orthopedic, you're going to look at the renal, you're going to take a stroke risk. I mean, it's very important to have all that put together. That's the last slide. People help me with these slides. I'm very happy. References. I can send you this deck later today.